In the last video, we discussed about the definition, classification, risk factors leading to fibroid, and how we have to examine and investigate a patient having fibroid. So, what are the complications associated with fibroid? The most common complication is degeneration, and the most common degeneration happening inside a fibroid is a hyaline type. There can be sarcomatous changes, but the incidence is only 0.2%. That is very less. So that is why fibroid is by definition a benign mass. The pedunculated fibroids can sometimes undergo torsion. There is chance of infecting a prolapsed or pedunculated fibroid. Sometimes there might be hemorrhage or bleeding into the pseudocapsule of the fibroid, and a fundal submucosal fibroid increases the risk of uterine inversion, and a pedunculated subserosal fibroid can sometimes get cut off from the uterus and or go and implant on the omentum and become a parasitic fibroid. Here there are two interesting phenomena which happens with fibroid, which is known as pseudo-mixed syndrome. In a pedunculated fibroid, usually sometimes there is right-sided hydrothorax and ascites, which is known as pseudo-mixed syndrome. This is not to be confused with mixed syndrome, which happens with ovarian fibroma associated with pleural effusion and ascites. So how do we manage a case of fibroid? Now, when do we decide to treat any asymptomatic fibroid? Whether it is to be treated or not treated depends upon various conditions. There is no size criteria for treatment of asymptomatic fibroids. They are just to be followed up every 6 months. When do we actually treat an asymptomatic fibroid? When there is a submucosal fibroid that might be the cause of infertility, when there is a fibroid that is big enough to cause moderate to severe hydronephrosis because of bilateral ureteric compression, and sometimes size more than 12 weeks, also an indication for operating or treating an asymptomatic fibroid. So the treatment options are medical management, non-invasive, minimally invasive procedures, and surgery. In non-invasive procedures, we have MRG and in minimally invasive procedures, we have uterine artery embolization and myolysis. Surgery options are hysterectomy, laparoscopy, and laparotomy, and myomectomy, obviously. Coming to the medical management of fibroids, when is medical management of fibroids done? When we want palliative care. Palliative treatment for fibroids is given to correct menorrhagia, correct anemia, decrease the vascularity of the tumor before going for a surgery of removing the tumor, decrease the blood loss during menstrual cycle while waiting for the surgery, and for preparing for minimally invasive procedures. If we give medical management, sometimes we can achieve to reduce the size of a big fibroid into a small one, so it helps to avoid a big vertical incision, and we can opt for a transverse small incision, and even we can avoid laparotomy and go for laparoscopy if we are reducing the size of the fibroid. So this is where palliative cure works. Medical management is curative for patients who are unfit for surgery, unwilling for surgery, and perimenopausal. So what are the drugs used for treatment of fibroids? Antifibrinolytics like tranexamic acids given at a dose of 500 to 1 gram, BD or TDS depending upon the amount of blood loss. It has an advantage of decreasing bleeding and correcting the anemia by reducing the bleeding. The second class of drugs are GnRH analogs, which can be agonists or antagonists. The most common GnRH analog is GnRH agonist leuprorelin or leuprolide acetate. It's given at a dose of 3.75 milligram every monthly or 11.25 milligram depot every 3 monthly. GnRH analogs reduce the size and reduce the blood loss per operatively. The mechanism of action is by reducing the FSH and LH level by inhibiting GnRH receptors, antagonizing GnRH receptors. They cause decreased GnRH production. So decreased GnRH leads to decreased gonadotrophin production, and decreased gonadotrophin leads to decreased production of sex steroids from the gonad. So hypogonadotrophic and hypogonadism is the mechanism of action of GnRH analogs. We do not use antagonists like cetrorelix, canurelix very commonly. The most commonly used drug here is leuprolide acetate. Because it is causing hypogonadotrophic hypogonadism, prolonged use of GnRH analogs can cause amenorrhea and menopause-like symptoms. Estrogen, as we know, is very important in calcium homeostasis, so prolonged treatment with GnRH analogs can increase the risk of osteoporosis. Entry androgens like danazol at a dose of 200 mg OD per oral for 6 to 12 months can be given. It reduces the fibroid volume and reduces bleeding. Important side effects are androgenic features in females like acne, hirsutism, decreased breast size, male kind of a voice, decreased libido. Here it is important to note that if we discontinue GnRH analog in a patient of fibroid, it causes the fibroid size to again increase. But if we are giving danazol and discontinuing it, there will be no regrowth of the fibroid. Progesterone antagonists like mifepristone at a dose of 25 mg OD for 3 to 6 months is also used. It decreases the size, corrects anemia. One of the important side effects is endometrial hyperplasia. Selective progesterone receptor modulators like ulipristal acetate. It started in the first week of menses, a single daily dose of 5 mg OD for 12 weeks. Even this causes endometrial changes. Any progesterone a modulator or antagonist will cause endometrial changes. So it is important that if you are giving mifepristone or ulipristal, intermittent therapy is advisable and annual ultrasound is done to see the endometrial thickness. If the endometrial thickness is persisting, then it is usually advisable to go for a biopsy. Please note here that ulipristal acts by inhibiting ovulation and can be also used as emergency contraception. Here the dose will be different from what we are giving in fibroids. For fibroids, we are using 5 mg OD for 12 weeks. As an emergency contraception, if we are giving ulipristal, it has to be given as 30 mg single dose within 72 hours of unprotected intercourse. Mirena, which is levonorgestrel intrauterine system, acts by endometrial atrophy and is used in treatment of fibroids. It causes 99% reduction in the bleeding intensity. One of the important side effects is ovarian cyst. Combined oral contraceptives are used as treatments of fibroid also. They act by inhibiting ovulation and inhibiting sex steroid secretion. So if sex steroid secretion reduces, estrogen production, progesterone production reduces, then there will be reduction in the size of the fibroid. Size reduction leads to decrease in bleeding and increase in hematocrit. So this is the algorithm which tells us how to manage uterine fibroids. If you are having a fibroid, then if the fibroid is large volume or there is a history of rapid growth, if this is yes, there's rapid growth, is a very large fibroid, then we have to rule out the risk of leiomyosarcoma by MRI and counsel the patient to go for surgery. If the fibroid is not very large and there's no history of rapid growth and the fibroid is asymptomatic, then we wait. If the fibroid is symptomatic, then we decide if the patient wants medical treatment. Yes, then first we use non-hormonal measures like NSAIDs, tranexamic acid. If there is an improvement, very good. If there is no improvement, then we have to decide what is the next line of management. by seeing whether the fibroid is distorting the cavity of or not. If it is not distorting the cavity, then we can easily put levonorgestrel intrauterine system or Mirena. We do not put Mirena in a distorted cavity because it increases the chances of expulsion of the IUS. And that is why if the cavity is distorted, we do not go for Mirena. We either go for GnRH agonist for 6 months, or we go for a combined oral contraceptive or progesterone trial. If these do not help, then we go for surgery. So if we have determined that we have to go for a surgical management, then we have to decide if fertility is desired by the patient and fertility is not desired. If fertility is desired, in that case we have to do uterus preserving surgery. So we just remove the fibroid, and that is known as myomectomy. If fertility is desired, if fertility is not desired but still the patient wishes to preserve the fibroid, we can go for myomectomy, uterine artery embolization, myolysis, and endometrial ablation. If the patient does not wish to get pregnant and does not wish to preserve the uterus, we can go for hysterectomy. So this is a picture showing the procedure of uterine artery embolization. Usually a catheter is placed through the femoral artery and is passed into the uterine artery, and we deliver embolics through it, and it embolizes the uterine artery, so the blood supply to the fibroid is interrupted, and this is how the fibroid shrinks. Myomectomy can be done by hysteroscopy, laparoscopy, laparotomy, vaginal route if it is pedunculated, and by robotics. If you are deciding to go for myomectomy and you want to correct the anemia, then it is better to go for iron supplementation rather than transfusion. Oral iron supplementation with vitamin C can increase hemoglobin by 2 gram per deciliter within 2 weeks of instituting iron treatment if the bleeding is controlled. Sometimes we may have to give intravenous iron also, like iron sucrose. What are the general principles to decrease blood loss at myomectomy? We can use a combination of approach like intramyometrial vasopressin plus vaginal and rectal misoprostol. We can achieve occlusion of vessels by putting a Foley's catheter tied around the cervix, or a polyclactin suture around both cervix and infundibulopelvic ligament. We can use vascular clamps like bulldog clamp that fit through the trocar and can be used to occlude the uterine artery temporarily. Loop ligation of the vessels of the myoma pseudocapsule also help in reducing the blood loss during myomectomy. So this is a picture showing the loop resection of fibroid in hysteroscopic myomectomy, and this is the post-hysteroscopic resection view. You know that the resection is complete when you can see the myometrial fasciculated fibroids. This is a picture showing a laparoscopic myomectomy where we are using harmonic. First, vasopressin is injected into the myoma to reduce the vascularity, and then we give an incision on this fibroid, and the capsule is pseudocapsule is cut, and the myoma is enucleated. This is the picture showing how a Foley's catheter is placed around the cervix to occlude the uterine vessels. As we know, the uterine vessels will be lying just lateral to the internal os, so Foley's catheter tied around it will compress the uterine, occlude the uterine vessels. So this is the picture showing injection of dilute vasopressin into the pseudocapsule of the fibroid. It reduces vascularity and gives us a better plane. Then incision, this is actually a laparotomy picture. Incision is given over the myometrium and continued until the pseudocapsule is reached. Then the fibroid is enucleated. And finally, the myometrium is closed in layers. Closure of myometrium always requires at least 2 layers of closure. So this completes the medical and surgical management of fibroids. Hope you found this video useful. Thank you.